without further ado, for this event to occur, we also need to thank our sponsor. Our sponsor is Vertis. They managed to bring Prof down to demonstrate the newer technique, which we hope that we can adopt to benefit our patient population. Now, they also very instrumental for me to visit Serbia at the beginning of this year. I won't tell you about the visa stories. I almost got police escort from immigration to the university, but that's for talks when we have drinks later on. But apparently that the whole country knows that I'm coming because I do not have visa trying to enter the country. But thanks to Prof, I got that problem sorted out and went to. So Professor Mićović is actually head of department called Daldenia Cardiovascular Institute. In their institute, when I was there, they have 30 cardiothoracic surgeons training. So 10 professors, 10 consultants, and 10 in training. They have 12 theaters, is that correct?
No.
6 theaters.
6 theaters.
They have 6 theaters. And I'll tell you why I'm getting to the theater and the time. Because when in the morning, they managed to do 2 rapid deployment aortic valve or mitral valve, they will finish just before 1 o'clock. And the next lot will take over from there to 7 o'clock. So that's why Prof can achieve 25 cases a day. Now the good thing is that when the clock hits 1:30, the shift change. Perfusionist, surgeon complete the case, but usually surgeon already finished the case, and they get to go home and relax a little bit for the afternoon. And whereas the junior consultants start operating at 1 o'clock to 7 o'clock. There's a team on call. I really like that system, and I hope that one day we can achieve that I just finished work at 1 o'clock at the 2 aortic valve. And with their hospitality, I've learned, I managed, and with Prof actually gave me a temporary operative license, and I managed to do 4 cases there, and it was really great. And I believe that this technique really gonna benefit our population. But without further ado, I'm gonna introduce our sponsors, Vertis, and they're gonna give a short speech. They're supposed to set up their tables, but I think they're a bit late today. So unfortunately, that's not gonna happen. But anyway, Natasha, the floor is yours.
Good evening, everybody. It's wonderful to see each and every one of you this evening. I know it's a cold winter's evening here, and it's heartwarming that you all could join and be patient enough to wait for us. Unfortunately, the case in KZN, Durban took a bit longer, so hence our delay. But as a company, Vertis is a growing distributor company, and we actually have 22 divisions, and we source out the most niche and best products globally to bring to the South African market. We're very proud to bring in Percival, which is currently the only true sutureless valve on the market. And it's revolutionary, it's changing the way surgeons think, and we want to support education and training, and that's where we want to develop everybody. So this evening would not have been possible without Corson. We have Celine Zanelli. She is from Italy, and she's been traveling with Prof as well, as we did this national surgical tour this last week. It's been fantastic, it's been crazy, it's been a whole lot of emotions, but we're super excited that we could be here this evening, and we're privileged and honored to have Prof Mićović present here today. He's broken many European records, and like James mentioned, he's done 25 cases in less than 12 hours, full stenotomies, and of recent they've done 10 no stenotomies within 12 hours. So Prof, we're very excited for you to join South Africa, and I hand over now to James to introduce you. Thank you.
Thank you, Natasha. Prof Mićović is actually currently head of department of Daldenia Institute. He's also the president of Cardiothoracic Surgeon Society in Serbia, as well as Pan Asia Cardiothoracic Society. Now, he's forte. He told me that he loves everything, like any surgeon does, but his favorite is still aortic surgery. Now, been spending a week with him, I truly benefit from his teaching, and he's also very charming. You will hear when he speaks. And so, without further ado, I would like to introduce Prof. Mićović and give us tonight's presentation. Thank you.
We were singing in the car, so I can continue. We have in Italian songs were very popular. Good evening, everybody. I'm really thrilled to be here. It's having James as a friend is an amazing thing. We actually being an education center for CourseSim and all these companies, give you opportunity to know people and to let you know such a gentleman as James. It was a visa problem, huh, James?
Yeah, exactly,
it was quite a visa problem, but you didn't know that we actually wanted to make a joke with you when you land to Belgrade to get the police bring you out. So, but at the last moment we said, no, maybe it's too much. So yeah. And the other joke I will tell you, during COVID, we had 4 surgeons from Turkey. So one morning we decided to test all hospital, and one of the Turkish guy was positive, and he came to me and said, "But Prof, I got 6 vaccines. How it is possible?" I said, "Man, but that's because you got 6 vaccines actually." So I know you are all tired, as we are a little bit. And I will give you a presentation regarding this novel technique. We try to teach. I hope you got from Belgrade a lot of knowledge, I'm sure. And I will talk now serious in next 15 minutes about aortic valve surgery, because no field in cardiac surgery changed so much as aortic valve surgery, thanks to our French cardiologist and thanks to a French scientist who invented TAVR. So TAVR came here, and you can see the paradigm shift that happened in 21st century actually. So a lot of people are introducing TAVR as the first technique. We are going to talk later about it. But then if we are talking about the patients on the different categories at different age, there are many ways of treating them. Are we going to give them mechanical valves, maybe? Are we going to give them the biological valves, and which one? And I will try to show you that the sutureless valve is a good option. Or to do in a very young population the ERAS procedure. ERAS is live again. Or TAVR, which I need to say that I disagree, but I will tell you why. So, role of sutureless technology in aortic valve surgery is there. So Percival was a knight, he was a knight, but this valve or platform is there for a long time, so since 2007. So now actually we have more than 100,000 implants worldwide, so 100 countries accepted this technology because it does good. So Percival Plus is a durable solution, and I will go shortly through the short-term, mid-term, and long-term outcomes. So trying to tell you why. Because the company is treating the bovine pericardium with the free new generation tissue treatment. I'm not a good singer, that's obvious. Which combines the reduction of phospholipids, no aldehyde toxicity. It's ready to use, no need to rinse. You well remember the rinsing in the jars and so forth. There are no calcification and much less calcification than the control group. So this is a futuristic design. It's actually a 19-hole stent, very flexible, very nice one. And we have these bovine pericardium sutured to that. All that leads with fully automatic collapsing is actually doing well, and it's actually gives us surgeons a fantastic tool to treat our patients. Some clinical studies, of course, were done because this nitinol is covered with carbofilm, so it prevents endothelialization. We've done 2 redos for endocarditis, late redos, and one case was very easy to take it out. The other was honestly not so easy, but not so tough as stiff stenting of a TAVR valve. So I will go shortly through the short-term outcome. These are the data from our clinic. So first 100 patients, average age, gender, nothing special. to say about the pre-op data. We've done at that stage a lot of mini sternotomies, and we started with the right anterior thoracotomy. So majority of patient minimally invasive. Size distribution was more or less, regular. And we have a very short cross-clamp time, you must admit, and a shorter CEC time. So then we figure out that actually with this valve we are more efficient. We don't want to keep our old patient on cross-clamp long. There are many patients with even with a low injection fraction, and having this valve is really beneficial. So shortcut outcome after 30 days was good. So AFib occurred in 15% of the cases, other rhythm disturbances, so everything else was good, but you can appreciate the peak and mean gradient, which are in low double-digit numbers. Permanent pacemaker implantation was low because we are not special, but we started quite late with this practice in 2018. So since then they figure out that actually oversizing the valve brings more permanent pacemaker implantation, so the incidence is rising. So since then, in all serious publications, there are more than 500 publications worldwide, the incidence of permanent pacemaker implantation is quite acceptable. First two patients, after we followed them, we called them back after 2 years. And then we figure out that the gradients, myocardial mass index and regression, hypertrophy, all was significant, statistically significant. So the results are actually very promising. And then we compared with the conventional valves. So trifecta, Evolus, Epic, we had a whole bunch of different ones. But what we noticed after 2 years, actually the gradient is very stable and even lower than at the beginning, and comparing to the conventional valves where the gradients stay, we can say it's stable, but it's slightly higher than after discharge. And then we are coming to patient-prosthesis mismatch. Why undersizing? In our heads it was always, we need to oversize the prosthesis, we need a bigger prosthesis for our patient to avoid patient-prosthesis mismatch. And this was a predicted one, which is not so, the result was not so good. But at the end, you can see the mid gradient of all of our patients in this group of the patients. And there were no clinical implication, and the mortality and morbidity was similar. Meaning that even at S size, because of this favorable hemodynamics, which are staying stable, very wide opening of the heart, of the valve, and nitinol stent, all that leads to a very low gradients, which you must admit, they're very good for our patients. And now let's skip to another group's results. So this is a group that I love. This is a group from Royal Melbourne Hospital, which I spent some times. I still have a good memories of those times. So they followed the results of 7 observational studies, and they analyzed it. And the conclusion is that actually the Percival valve demonstrated very good 5-year mortality, hemodynamics, and morbidity outcomes. And then the longest follow-up, 13 years. Now we have a 15 years, but this is the 13 years from the same group. This is group from Leuven, from Belgium. They've done now more than 1,000 of these valves, and these were the data of almost 800 patients. So single center all-comer study, because it's their choice, their prosthesis of choice. Long follow-up, 3 subgroups, and they follow up the usual primary and secondary outcomes. Okay, so these are baseline characteristics. Usually the median ERAS score was a little bit higher than ours, and only 30% of minimally invasive surgery, which was, but then I know from guys over there that they are increasing number of minimally invasive surgery, but they have quite a lot of combined procedure. Will be fine with this prosthesis. Do really well in combined procedure, mitral repair, mitral replacement, or CABG. So study results, early outcomes were really favorable. So ICU stay of 2 days, hospital stay. James know that I disagree with this length of stay, but I heard that actually in South Africa, the patients are staying quite long, which we can discuss later.
Yeah.
And they're staying long. I don't know why. We are discharging on day 4. We love to discharge them on day 4. The study, the late outcomes, median follow-up of 7 and maximum follow-up of 13 years. And you can see the favorable results: survival, freedom, and structural valve deterioration. It goes up only 0.54% per patient year, meaning after 15 years you will have 7% of the patient that will face a problem with their valve. All the rest will do good. So this is a discharge echo. So peak gradient and mean gradient are almost the same, and you can appreciate the latest echo with even lower peak and mean gradient and very low paravalvular leak occurrence. It's only 1% of the patient. So this was at the time when I was doing this. So this was the longest follow-up, really real-world patient population. 10-year freedom from ear intervention is 94%. Why don't we put this valve in the 60-year-olds? I had a lot of questions the other day about the cutoff age for these valves. In the case of perceval valve deterioration, valve-in-valve is valid and safe option because this valve is very flexible and it's actually enlarges up to 2.5 millimeter in diameter. There are reports of valve-in-valve after perceval. Actually, it's very easy for our friend cardiologists to put a TAVR valve inside, and they can put even in the smallest perceval valve. So surgeons should not be afraid to put the small size perceval valve. And this is the overall summary of this. So this, I think, is very important. We are looking forward to see 20-year follow-up and to do more and more valves, because freedom of rear intervention, excellent hemodynamics, and survival is better than expected. And now the real-world registry, almost the same, 55 institutions. You need to be 56th to do these valves, because they are doing well. We are quite happy. We've done more than 400 since 2018. Of course, during COVID, we didn't work much. And we are quite happy with the results. We are strictly following our patients, and there is no patient that came back for structural valve deterioration, only unfortunately to a carditis patient, which is not much. So this is one study, 55 institution, total of 1,700 patients, and showed that this valve is doing good. And now the discussion we want to make. Are there any cardiologists? Amen. My mother was cardiologist. I'm a friend, so I'm not the best. I will tell a few words about it, and then we can discuss. I'm not involved in TAVI. Okay, so we are doing annually 750 aortic valves, surgical valves. We have a very busy TAVR program, so yearly, one or 2 days they're doing TAVRs, and they're doing 200 per year. But we are sitting together as a heart team, we are sitting as a friends, colleagues, and we are discussing each patient. Let's go shortly through a few slides like this. This was published in JACC of Asia, so they compare sutureless rapid deployment with TAVR and with SAVR. As you can appreciate, the sutureless valve do better. And then the big study, long-term results of such as 9 years, 500 patient matched. Claudio Munaretta from Brescia, he's well known in Europe, really well-known surgeon. So you can appreciate that the gradient mortality, pacemaker, paravalvular leak, and other things are favorable for surgical valves. I'm not saying that the TAVI shouldn't exist. Of course, I love TAVI, and we have a lot of patients for TAVR, but there are certainly a huge population of patients still surgical candidates. Benefits and pitfalls are Perceval by Massimo Bonacci in the Frontiers 2022, and the Perceval has proved to be reliable comparing to other prostheses. I will stop with TAVR. I will not do them anymore. Post-TAVR surgery, that's the problem. I don't know, James, have you done any?
No.
No, it's very difficult. The mortality goes up to 15%, unfortunately. Maybe we will get better with it with time. It's the need of this cardiac surgery is actually increasing rapidly. It's the most rapidly increasing number of cardiac surgery procedures. I personally think that the TAVR is not for us. It's for cardiologists, but we need to learn this surgery because it's tough surgery and it ends usually as a root surgery, which means that needs to be done with very, very experienced aortic root surgeon. So that is the problem that we were not thinking about, and I'm always saying to a cardiologist, man, we are not going to take anybody to accept anybody's wishes when he's 50 or 60-year-old to get TAVR. We need to sit with every patient and tell him the risk and benefits of each procedure. So that is the way to go. I think we need to go together. Why do it minimally invasive? Because it's much better. They're going home sooner. They recover well. And since we are doing minimally invasive surgery, we are much braver now. We are accepting more risks. Really, the patients are doing much better. 78, 77, whatever. They do well after aortic valve surgery. And I will show you the different techniques where we use this Percival valve. So mini sternotomy is for a purpose of training. More or less everybody can do it. It was a tough case today, though, terrible, but can be done with a CABG to RCA or mitral valve repair. And then redo surgery. We have more than 30 cases done like this. So on the virgin valves or after prosthesis, we had to take out the prosthesis. So through the inverted T sternotomy, to replace the valve was successful in 30 cases. This is the one case where actually Percival saved our life because it was heavily calcified freestyle prosthesis implanted as a root years before, and so we implanted Percival inside, and it was good. And then we come to a minimally invasive surgery, so 4 or 5 centimeter incision in the anterior line, or you will see in the anterior axillary line do well. So we can cannulate in the groin or centrally and replace this prosthesis. You don't need much space, although even with this technique, cross clamp time and CPB time, of course, the time of operation is shortened than with conventional valves. Auxiliary approach is something that we started using like 6-7 months ago. We didn't show you that.
No.
Oh, wow, we couldn't show you everything. You need to come again.
Yes, sounds like it, but I'm not going to be escorted by police this time, right?
So, yeah. So we will get these out time. So the incision is anterior axillary line, so you can appreciate how nice it is. There is no scar at all for the patients. This is a young lady actually that we implanted the regular valve, conventional valve, but I'm using this slide to show you how we are marking the patients, and you can appreciate this view from axillary line. And this is the case with Percival valves, as you can appreciate on this side. So actually aorta is very close, everything is direct vision, and everything is very nicely doable. We've done more than 20 of these cases. We are implanting now conventional valve through this approach, and we really love it. Not just me, but the other guys. Our results promising so far. No AR, very low pacemaker incidence, and for us, which we are a very high volume center, so 12 cases per day, 20 admissions. We need to have a lot of discharges daily. We are keeping the patients, and we are waking them up very early. They are leaving ICU on the day 1 and leaving hospital on day 4 with some kind of monitoring and follow-up by a GP or by us. We have a telemonitoring system to follow our patient. So to make the story shorter, because it's late, and I'm sorry once more for being a bit late today. So we have in our hands a great tool with excellent hemodynamics. It's durable. We know it's proven it's durable. We have a better midterm results comparing to other prostheses, and it's a perfect tool for minimal invasive surgery, which I think, I'm sure, this is the future of cardiac surgery. We need to go on the small incisions. We need to make this surgery like appendicitis. It's no more surgery for lying 14 days in a bed in a hospital. No way. It's suitable for small annuli, so this is our other indication, very calcified aortic root. I faced one in Charlotte Hospital in Johannesburg. I don't know how we finished it. It was really terrible. Very small annuli for combined procedure, of course. And most important thing, I think, at the end is to, when we are talking about a long-term or treatment for our patient, this is valve-in-valve friendly prosthesis. I want to thank you once more to be here in such a big number, and it's really, I love being here. Thank James for calling me, and I really appreciate being with you. You're my friend. Thank you very much.
Thank you.